Hello, welcome to our 30th lecture in this new and updated Drugs and Human Behavior series. We have started discussion of depression in lecture number 29. If you have not had a chance to take a look at that, it outlines very clear information about what depression is and updates our view of what depression is in the brain. But for this particular lecture, we're going to focus on first-generation antidepressants. First, I want to start off by saying if you are someone you know is depressed or suicidal, know that help is available. I have here the Suicide Prevention Lifeline, phone number and website, as well as links to depression.org, which has lots of resources. So please reach out if you feel you need help. As a reminder, these video lectures are for educational purposes. Please always consult your physician or pharmacist for any questions about medication you take. So in this lecture, we're going to focus on first-generation antidepressants. In upcoming lectures will be SSRIs, other reuptake inhibitors, some new frontiers in antidepressants. So that's when we'll talk about esketamine as a new drug treatment. And then I'm going to finish out this series on depression with a whole take on alternatives to drug treatment and potential ways to prevent depression in the first place. So let's get through talking about these first-generation antidepressants. Some of these are still in use, some more than others. They're not generally drugs of first use for treating depression. If we're going to go the drug treatment route, generally we start with selective serotonin reuptake inhibitors. But it's important to understand these drugs as well because they are still in use for people who don't respond to those SSRIs. So we'll start with what are called tricyclics, and then talk about what are called monoamine oxidase inhibitors, and then heterocyclics. So this is sort of the evolution of antidepressants. We've gone from these tricyclic drugs, which are fairly toxic, and MAOIs, which can also be fairly toxic, and moved on to selective serotonin reuptake inhibitors, as well as selective serotonin and norepinephrine reuptake inhibitors. Now we're in a new era of antidepressant treatment where we're not focusing so much on serotonin as we have in the past, but more on how we can influence brain-derived neurotrophin factor and cortisol. So reducing cortisol release by the stress response system, the HPA axis, and also boosting those BDNF levels to try to improve neurogenesis and to solve some of the neurodegeneration that has caused the depression in the first place. So tricyclic antidepressants are a class of drugs that all have a characteristic three-ring molecular core. So these are the amitriptylines and norepinephrines, which are the sort of most commonly talked about in this class of drugs. Obviously, there's a fairly large list of these drugs, but amitriptyline is certainly one that has had a great deal of use in the past. We'll talk a little bit about these drugs and some of the issues with them. So TCAs, the tricyclic antidepressants, cause two pharmacological action that accounts for both their therapeutic effects and their side effects. These have a really significant side effect profile, which is one of the reasons they've fallen out of favor. So they block the norepinephrine and serotonin transporters. So they block reuptake into the presynaptic neuron. So this is sort of the first dual-action antidepressants. We're now going back to dual-action antidepressants. So this is an important part of how these drugs work. Unfortunately, they also block postsynaptic histamine and acetylcholine receptors. And this is what is associated with most of the problematic side effects. So this includes sedation. So any antihistamine is almost always sedating. Cognitive dysfunction occurs because of the blockade of the acetylcholine receptors. Those anticholinergic actions can be both from bothersome to toxic. Remember, those cholinergic receptors are also involved in the autonomic nervous system. And so you might be very cautious about anything that's anticholinergic. Norepinephrine and Desyrel seem to be the best. That is, they have the least anticholinergic and antihistaminic actions. So they block histamine and acetylcholine receptors less, and so they probably are a better choice of this class of drugs. So all tricyclics have three important clinical limitations. Very slow onset of action, so it takes a long time for these drugs to have any effects. They have very significant side effects, which oftentimes keeps people from getting to the point where they're going to actually help them because they go off of them. Importantly, these are drugs that are cardiotoxic and potentially fatal in overdose. And in a depression patient, this is not an ideal situation. So this is, I think, a more dangerous drug, type of drug to be giving, particularly to a depression patient. And so it's one of the reasons why this drug oftentimes gets limited use. So some conclusions about tricyclic antidepressants from the literature. They're no more efficacious than selective serotonin reuptake inhibitors. The potential side effects and toxicity are much greater than the SSRIs we more commonly use now. And we've seen that SSRIs show a higher rate of patient comfort and compliance, and so they are a better choice of drugs as a class than the tricyclic antidepressants. But they're still available, and again, have limited use, but there are certainly better drugs to go with. The next class of drugs are monoamine oxidase inhibitors, or MAOIs. These drugs block the synaptic enzyme monoamine oxidase, which breaks down the monoamines. So primarily norepinephrine, dopamine, and serotonin. So this is an enzyme that regulates the amount of monoamine neurotransmitters in both the body and brain. Unfortunately, the use of these drugs are limited by potentially fatal interactions when taken with certain foods and medicines. And so this really limits a patient's ability in terms of their diet and in terms of what other drugs they might take. You've probably heard or seen on almost every drug you'll ever take that says, see your doctor if you're taking an MAOI before you take this drug, because there are a lot of potential interactions. Interest in these drugs has remained strong. They can be as safe as SSRIs. They can work in many patients who respond poorly to both tricyclics and SSRIs. So if we haven't had any luck with other drugs, this is a potential drug as well. They're particularly effective for the treatment of a wide range of depression. And so oftentimes we see a better response or sort of wider response profile than we might in some of the other drugs. Now, interest is still strong in these drugs. And we're getting to the point where we might be able to select either an MAOI or an SSRI based on your genetic profile. And so there's an interest in that, and there's a lot of work being done in that area. Not confident enough in terms of the data to talk about the specifics of that, but there is a growing interest in that field, and I think that's an exciting realm we'll be getting into. So, that gets us to the heterocyclics, or what we call atypical antidepressants. We're going to talk about two drugs that are currently available. First, ludiamel, or Amitriptyline, was developed in the early 80s. Biggest take-home message here is it offers few therapeutic advantages, can cause seizure, and can be fatal in overdose. Amoxapine, another drug in this class, is the second atypical antidepressant. Unfortunately, may produce Parkinsonian-like side effects because of postsynaptic dopamine receptor blockade. Not generally a first-choice drug, and again, overdose can be fatal with these drugs. So probably not good choices in this class. Trazodone has been shown to be as efficacious as Tricyclics. It has a unique mechanism, so it has some strange side effects, can cause drowsiness, can also cause priapism, which is an erection lasting more than 4 hours, which is an unusual side effect for this class of drugs. It is less anticholinergic, and so you get less cognitive dysfunction than you might with a typical tricyclic. A different version of Trazodone is a new formulation, which is called Eleptro, which has been approved for treatment of major depressive disorder in adults. Unfortunately, it can cause some daytime sedation, so that can be problematic. So again, it's the side effects that often really are the stumbling point when it comes to these drugs, because they do have very significant side effect profiles. Anafranil is a new tricyclic antidepressant that inhibits mainly serotonin reuptake and some norepinephrine. This has been classically indicated for obsessive compulsive disorder, but also for depression, panic, and phobias. Its efficacy is equal to the tricyclics but it is limited by side effects. So again, significant side effects. are the stumbling block to a lot of these first-generation antidepressants, which is why a lot of these have been sort of left in the past and are less likely to be used now. Bupropion is sort of the standout in this class of drugs. It's also known as Wellbutrin or Zyban, depending on what you're being prescribed it for. It is a dopamine and norepinephrine reuptake inhibitor. It results in an anti-craving action and is good for treating anxiety, restlessness, tremor, and insomnia. It's used to treat depression, ADHD, and nicotine dependency. So Zyban is the drug used sometimes for treating nicotine dependency. And you can see my lectures on nicotine for discussion of both bupropion and other drugs used to treat nicotine dependency. Unfortunately, it can cause anxiety, psychosis, and seizures. Can improve sexual functioning, so it has been associated with improvements in sexual functioning in both males and females, and it's not as effective for panic disorders. And I'm sorry, I think I misspoke a moment ago. Anxiety, restlessness, tremor, and insomnia are potential side effects. They're not treatments, or isn't a treatment for that. And so this can cause anxiety, and so it's not effective for people taking panic disorders because it can increase that anxiety. And that's because it increases both dopamine and norepinephrine. So please keep that in mind. But this is a good drug for some people for both depression and for treating ADHD, as well as trying to get people off nicotine. Right, that's our first look at first-generation antidepressants. Once again, you can see these resources for more information on any of these or other drugs. Thank you. Next roundup, we'll be back with selective serotonin reuptake inhibitors.